being the CEO of your license really means you really stop waiting for that system to keep you safe. And you start managing your competency, your boundaries, your decisions like your license depends on it, because in the real world, it does.
If we want new nurses to stay in the profession, we must teach them one powerful truth. You are the CEO of your license. In today's episode, we break down what that mindset really means. We're diving into the boundaries, the confidence, and the decision-making skills every new nurse deserves, but was never taught in school. Welcome to Lippincott Spark, Illuminating Nursing Education, the podcast that fuels teaching, innovation, and leadership. I'm Dr. Kelly Drees. Each episode, we spotlight bold ideas, expert voices, and practical strategies to help you teach smarter, lead stronger, and stay inspired. Let's spark new thinking and dive into today's episode. What if the biggest reason new nurses leave has nothing to do with clinical skills and everything to do with the hidden curriculum we never explicitly teach? In today's episode, we explore why structure alone doesn't improve retention and what educators can do to empower new nurses before they reach the breaking point. Today, our special guest is Kati Kleber, nurse educator, national speaker, author, CNO of registerednursing.org, and founder of Fresh RN. With extensive experience supporting early career nurses, Kati brings honest insights into confidence building, boundary setting, and the realities of onboarding. Welcome, Kati.
Thank you so much for having me. I'm so glad to be here.
You're welcome. You've spent years listening to new graduates in ways many of us never get to hear. And I think your perspective really could help us understand what's happening beneath the surface. So, to ground this conversation, I want to begin with something foundational. What do new hires think and feel, but rarely share with their educators, preceptors, and managers?
I'm in a unique place because I'm not their direct educator on a unit, and I'm not their colleague on the unit. So I get the uncensored, oh my gosh, these are my thoughts, that they're not going to bring to their manager or their educator. Although I think a lot of managers and educators would be like, hey, this would have been helpful to know 3 weeks ago. So I like to liken new graduates, or maybe not even just new graduates, new hires into the acute care world, more specifically, kind of like you're being onboarded onto a basketball team. I played basketball in college. I've coached. It's a very similar ecosystem, fast-paced. There's a baseline skill level of, I know basketball, I know about nursing, but there's a very specific way it has to be applied on this unit, in this hospital, with this very specific patient population and the personalities that are already here. So being a rookie on a basketball team is kind of like being a new graduate or a new hire into a nursing unit. So I think it's important to have that mentality of understanding where their headspace is. They want to be competent. They want you to think that they're capable. They want their colleagues to not think they're dumb. Very basic desires. So they're not going to be sharing all of this stuff the second they notice a red flag with that a colleague said something that was kind of off, or maybe a little rude and not appropriate or whatever. They're not going to bring that stuff immediately. They're slowly feeling out personalities on the unit, figuring out who the informal leaders are and who's not. And a lot of them are entering the workforce for the first time. So they're understanding what real professional boundaries actually look like and going from the school ecosystem to the professional ecosystem, which are very different. So I think it really comes down to they don't know what's reasonable and what's not. And it takes time to really figure that out while maintaining credibility. So they're not going to tell their educator if they hate this residency program and it's a waste of time. They're not going to tell their manager that their top informal leader who runs the unit is slyly hazing them. They're not going to share that information. Much like a new rookie on a basketball team is not going to say, hey, the best player is so rude to me in the locker room that it's getting to the point where I just want to leave. They're not. So I think it's important to remember that they're not just going to bring that up right away. It's going to get to a certain point before it is brought to you. Hopefully, they're functioning in a way where they're trying to handle things independently that might not be going so great. But I wouldn't expect them to share that information. I would expect delays, second guessing, waiting so that they can figure out, is this reasonable or not? So it's a tough place to be as an educator and a manager. I feel like it's also like being a parent of a teenager. You don't know what they're feeling. They're not necessarily going to tell you, but you have to be emotionally aware enough to know they have thoughts and feelings. They're not going to candidly share with me. Just because they're telling me I'm doing a good job doesn't mean I actually am. Or I might be doing a really great job. It's hard to tell. So I think those are the kind of things that, as tough as it is to be an educator and in leadership, that you're not going to know all the little candid things that they're saying, but that's an important thing to remember.
Absolutely. And I like how you said that preceptor, that manager, being able to have that great situational awareness, that their eyes are wide open, that these are feelings that the new nurses coming onto the floor may be having. And sometimes we miss those cues. We miss some of those signs. But I think that gives us an important window into kind of that lived experience of that new grad coming onto the floor, and kind of building on that insight. I'd like to explore how what they feel internally lines up with what we believe we've been providing externally, meaning where do you see the biggest gap between what educators believe their residency or onboarding provides versus what new nurses actually experience? Because we build this out, right, with great intention, but what are these new nurses actually experiencing?
Yeah, and I do want to say great intention. Like, as an educator, you're trying so hard to ensure that these new hires have a great experience. But I do think the biggest gap really is in curriculum delivered versus support experienced. So I think educators mostly judge whether maybe a residency program or a course by whether it's structured appropriately, it's comprehensive, it's a professionally run, it meets the outcomes that we've identified. But new hires, new nurses really judge it on whether it changed what the shift felt like. Safer execution, fewer blind spots, less isolation, maybe like a reliable human backstop. So I think that's the biggest gap. And what's interesting is with my platform, I sent out a survey just to ask anyone going through a professional onboarding at a hospital, do you have a residency program? What did you think of it? And then I also sent the similar one to educators. Hey, tell me about yours. So the results were definitely very interesting. I had 40 nurses respond telling me about their experience with an onboarding program. And there was a big gap between what new nurses thought and what educators thought. Unfortunately, I asked them to rate their residency program 0 to 10. 10 being, I'm so supported. This is amazing. I'm going to stay here. I love this hospital. And 0 is, this is the worst. I left immediately. The mean ranking from 0 to 10 was 4.26 from my nurses. And then the educators, now my sample size was much smaller naturally for the educators, was only 8, but they personally rated theirs 5.88. So still better, but not great. But I think that the split matters. Educators see this is good enough with areas to improve, but I think new nurses are experiencing, hey, this really isn't meeting the moment of what I need. Residencies often really succeed at providing information and structure, but they can fail at providing operational execution, how to run a shift, manage interruptions, prioritize and sequence in real time with real constraints, and how to recover when a plan breaks. So I think that's a big gap between the two things. We can write our outcomes out and we've met them in our educational thing, but how that physically gets applied to the bedside environment, it's a big difference. And it really depends a lot on what I've learned, a lot on preceptors. And that aligns with my personal experience too.
So you've seen that. Okay. Yeah. Yeah.
Yeah. I mean, I really feel like your experience, whether or not this residency program is 10 out of 10, it really hinges on that preceptor. I think the preceptor is the make or break operationally because they're the ones showing you how to do this and that in a very micro prioritizing way at the bedside practically. I think that a good preceptor can make up for a bad residency program, but a good residency program can't make up for a bad preceptor.
Okay. Yeah. Speaking of on those same lines of preceptors, having that very influential relationship, right? It's like you said, make or break that transition to practice. So what can faculty and leaders do to better support and prepare and empower preceptors so they feel confident and capable in that role? What could we be doing different? Because we've got academic leaders and faculty and SIM coordinators. We've got lots of different, the audience listening. What can they do to help support preceptors?
So the first thing is going to sound really crazy, but you would be surprised at how many times I get emails about this, but tell the preceptor they're going to be precepting somebody.
Surprise.
Surprise. So precepting, often not paid more. I was never paid additionally. Not that I needed some massive sum, but this is a lot more work. As a bedside nurse, if you are highly efficient, you will get through your shift just doing your tasks. But now we're adding someone to you that you have to explain everything to. It is a big work ask that is often maybe just, here, you just precept. I think there is a disconnect there, I think, between non-bedside roles and bedside roles of how big of a deal that is. Because that new precept or that new hire, they may need a lot of hands-on stuff. That doesn't mean they won't be an amazing nurse once they get the appropriate education. But some need a lot more explanation, a lot more reps, and that needs to be provided in such a structured way. And if you have someone who's been a nurse for 6 months, a year, who's still getting their own footing, this is a big challenge. I remember when I was a new nurse and I was asked to have nursing students, and I was a new nurse. I was a month off of orientation, and nursing students look at anyone that has RN behind their name really knows what they're talking about, right? So they ask them all the questions and why are you doing this instead of that and this and that? And I was very much I still don't fully understand why I'm doing all of these things. I know I need to do them, but I haven't had the space to really put those pieces together, but I know they need to be done. And so to stop and explain was very humbling. It made me very nervous, and it also put me already more behind. So I came off as more cold and cross than I really was. I'm a warm, I love teaching, but at that point in my development, I was not ready for that. And I think I gave, in retrospect, some of these nursing students the wrong impression of me because I was shell-shocked at, oh my gosh, I'm still trying to do this, and I really don't understand why I'm doing this. So I think if you're in a leadership role, knowing what you're asking of preceptors, and I know not everybody is going to be an amazing preceptor, and precepting truly, if you have a full unit of people, you've got 3 or 4 people who are unicorn amazing teachers because they can do and teach at the same time and emotionally support. That is high level of operational execution and emotional intelligence. Those are multiple skill sets working all at the same time. But then there's a lot of people who can do an okay job of precepting that do need that support that, hey, you know what? I need you to be reliable. I don't need you to be perfect. We are putting a lot on your plate, and sometimes without any warning. So telling people when they're precepting, I think, is a big deal, and giving them some idea of what to do. Even if that's something as simple as roughly by week 2 on this unit, this nurse should be able to do X, Y, and Z. And not a competency packet that's an inch thick, but broken out into timelines on your unit. If I was on a new preceptor on a unit and I was like, okay, by the end of week 2, by the end of 6 weeks, we got to be doing X, Y, and Z. Okay, that gives me landmarks. That gives me a place to be. So I think that is really, really helpful, as well as telling them how to approach different personalities. So I know in adult learning theory, precepting course generally is what's given to preceptors, so it can hit all the preceptors on all the units. Here, this is how you teach adults. While that can be very effective and helpful, that doesn't always transfer to the nitty-gritty of individual units, which is what I think the gaps really are. So if there's any way to provide customized to your unit, hey, we should be doing chest tubes. By the 4th shift, they should know what to do with a chest tube on this cardiovascular. Those kind of very clear markers for the new preceptor is really helpful. And also, structured way on how to give feedback. That was one of the biggest challenges for me is I'm very positive, but telling somebody who's really trying hard that they handled that situation terribly, but in a tactful way is really, really important.
It's about navigating those crucial conversations and that crucial accountability because there are lives at stake here. You want to be able to provide that feedback that is going to be constructive, but also in a kind way where you are elevating them, empowering them, helping them grow. I mean, that's the point. Otherwise, that's why we have, I'm sure, a lot of that turnover. So how are we, able to really, I'll say support that preceptor in that important work as they onboard those new graduates. I have heard you talk about these consistent themes about the emotional load new nurses carry, and it can be quite heavy. So I'm wondering how you see this show up in onboarding. So they've graduated, they're coming onto the floor. How can faculty proactively address it before it leads to burnout and self-doubt?
Yeah, I think one of the biggest things is reality expectation setting. So there is such a big mismatch between what the new hire thinks they need to display to their staff, to their leadership to look competent, and what they actually expect. So I was a new grad. I thought I needed to be buddies with those doctors as soon as possible. And I needed to know all the meds, and I needed to understand the ABGs and how to do, the textbook knowledge. I thought that was really what they were looking for. And then, I experience it myself and then interact with a lot of nursing leaders. And what they're expecting is not that. They're expecting someone to be coachable. They're expecting them to be reliable, teachable, able to be a professional, and they'll teach the clinical skills. And you'll learn that stuff. You have your baseline understanding of nursing. Let me teach you the skill set here. But those qualities they can't teach is you taking ownership and accountability and wanting to do things the right way and being a professional. So I think that as a faculty preparing these students to enter the workforce, that is a critical thing to provide because we are measuring them on these multiple choice tests, the NCLEX, all this. It's very knowledge-based, but we need to also tell them how employers are really looking for these value-based things that are in their behaviors that are not measured by a test. And that if they can do those things, which do all require emotional maturity and professionalism, but if they can display that with a commitment to learn the things that they don't know yet, with a level of self-awareness, I think that sets up the graduate better to be in this professional world.
That connects us to directly with something you teach so powerfully. It's the idea that new nurses must see themselves as professionals with agency, not passengers in the process. So you often say, Katie, that new nurses must become the CEO of their license. What does that actually mean? What does this mindset look like in practice? And how can educators help students develop it before graduation?
This is something that goes to that transition from being part of the school ecosystem to being part of the professional ecosystem. So to me, being the CEO of your license really means you really stop waiting for that system to keep you safe. And you start managing your competency, your boundaries, your decisions, like your license depends on it, because in the real world, it does. So in nursing school, you are part of this structured educational ecosystem. Your instructors are responsible for teaching you. You're paying them to do that. Your success is clearly measured by goals, outcomes, checkoffs, exams. Environment is really designed for your growth. But after you graduate and you get into the professional workforce, that world really is over. But it doesn't feel like it because orientation sure feels a lot like school.
Yes.
You go straight from passing the NCLEX into this very heavy teaching environment. And it feels like this it feels like a continuation of school, but it could not be more different. And it's critical that faculty prepare them to delineate those two things, because after you graduate, and you get that license, you are responsible for maintaining it and protecting it, not your school, not your employer. It's very easy to get into a job and think your employer is going to manage your license for you. I can't tell you how many times a colleague's license lapsed because they assumed that their employer was going to tell them when it was expiring. And it's like, no, that's your job. I was literally on a unit when a nurse had to leave because they realized, oh, their license expired last week. You gotta go.
Uh-oh.
And they were like, oh, I thought they just tell me when I need to do that. No. You're onboarded into this complex system that completely relies on your safe participation. So you're going from paying to be educated to being paid to provide a service. So you're showing up to your employer and you're providing a service that you're only able to provide because you have this license that you worked so hard to get and proved to a state board of nursing that it is safe to provide you one. So you have a business relationship with your employer. But I think it's very easy to confuse the relationship between the employer and the patient. Your relationship with your patient is a therapeutic relationship, which you learned all about in nursing school. But I do think there is this piece of education that should be provided in school where you have a business partnership with your employer. They're compensating you and providing you benefits so that you reliably and safely show up to provide a service that you have demonstrated you can provide nursing care. So what that looks like in practice is really knowing the guardrails. So you know your Nurse Practice Act. You know what you can and you can't do in your state. And obviously that changes when you get into APRN roles. That you are tracking your competency honestly. So you're not saying, yeah, I know how to insert Foley catheters and maintain them on this unit when no one's ever shown you how to do that, like that kind of thing. Well, if you don't genuinely understand the right way to do something that you're asking, that you're looking at policy, that you're not just saying, oh, this nurse that was trained 20 years ago knows the right way to do it. I'm just going to trust everything. I want to understand the right way to do. I'm looking up the latest policy on certain things. I know you can't stop and policy search every single time, but that you have a commitment to do things right because no one else is going to make you do that. Your school's not there to do that. Your employer's expecting that you do that. I think another thing, the way that looks like in practice that nursing schools do need to really empower these graduates is that you protect that asset under pressure. There are a million great employers out there that are not going to put you in this situation that's unsafe. But unfortunately, in the real world, there are places where you're going to be in challenging situations where you do need to say, wait a second, I'm being asked to do things that I cannot safely do. Then I need to be able to protect this asset because I can always get a new job. I cannot get a new license. I've worked for wonderful employees that I never felt like, and I know so many nurses who have never been put in that situation, but we do live in the real world, and having the situational awareness to know that the person who cares the most about my license is me. Yes, my employer absolutely cares, but I'm the end here. I'm the stop here. I need to care the most about it. So I think that teaching the explicit shift from school's an educational model, work as a professional accountability model. And those are very different situations. So teaching that in school, I think, is important. Practicing real scenarios in nursing school. Hey, when do you accept that answer from that physician? Or when do you push back?
And how, right? How do you push back, right? That's another skill. Yeah.
Assertiveness skills, yes. I think, start in nursing school. And those are the bedrock for things like boundaries and self-advocacy and preventing burnout. I really think the foundation of that is teaching assertiveness. And I think in nursing school also, it's hard to do this, but grading students on not just, did you know the answer? Could you answer the question correctly, but did you recognize the risk and act early? There's a quote where it's like, you're not learning this information to pass the exam. You're learning it so that you can, because you're the last step between the patient and the grave sometimes, and you need to know the right answer. And it does put a lot of pressure on nurses, but when you get into very high stakes environments in schools where you're like, I'm fighting for the death for every question, you can lose your North Star here of, why am I learning this? I'm learning this so I know in the clinical environment what to do.
Once we start talking about identity and agency, it's actually impossible, I think, to ignore the hidden curriculum. It's those skills and scripts that often determine whether a new nurse sinks or swims. So, Kati, I'm wondering what elements of the hidden curriculum, like assertive communication, boundaries, self-advocacy, should faculty intentionally integrate into the academic and clinical learning environment?
Like I said, like assertiveness, I think, is really this foundational thing. And while the ideal state is that adults coming into a nursing program know assertiveness skills, like that's not the reality of the world that we live in. But this is a field that definitely requires it, especially when we start talking high acuity areas and situations where your ability to communicate assertively under pressure can really make measurable differences in patient outcomes. So I think that it is something we should teach first semester of nursing school. And it doesn't need to be this full credit hour by any means. This could be inserted into your foundational nursing courses. But, we get a lot of questions that say, what order would you question? And we can identify that. But honestly, that can honestly be the easy part. How we question it to the physician with 28 years of experience when you've been here for 3 weeks. That's the barrier. That's the rubber meets the road, the thing that the bedside nurse is scared. They could know the right answer in their brain, but having the courage and the tact to do that in a high pressure situation is a completely different skill set. And if we are able to give a definition, explanation of assertiveness early on, and really assertiveness simply is the ability to maintain connected while disagreeing. So we're being respectful, communicating that we disagree. We're not being aggressive. We're not being a passive. And I'm speaking for ourselves. We cannot control what anyone else does. You are probably going to talk to passive people and aggressive people that you have to be assertive with. And that's just the reality of working with humans. And really, we need this skill in almost everything. But that middle ground is very uncomfortable sometimes, not being aggressive and not being passive. It requires that emotional maturity, and it takes a lot of practice to execute. So if we can identify what assertiveness is and what it looks like early on, and then throughout a nursing program, conscientiously point it out. So when we have the question, what order would you question? Then we can follow, how would you question that? What is a script, a talking point that you could say, which in the support that I provide on my platform, I get a lot of the scripts really help me because they're in this scared state. They're not sure what to say. But if we can give them, hey, consider saying something like this, that really helps connect those dots between what I know I should do and how to actually make that happen. And then as they get more comfortable in those situations, then they can make their own script or their own, custom response to things. But they really need a simple place to start. So if we can define it early and throughout a program, really call out intentionally when this would be an assertive way to do this with patients, with family members, with our own colleagues, with providers. I think those are all really important things. And if you can have somebody graduate a nursing program, not being perfect in assertiveness, but very much understanding what it looks like, how to not take things personally in this professional environment where people say things that they're not proud of and are some in really bad places, that we can maintain professionalism throughout that. I think that we're really setting them up for success as graduates.
And I'm not sure if you've read Dr. Cynthia Clark's, her recent work in 2024. She talks about this therapeutic communication strategy, which is exactly what you just said, which is working off a script essentially, but it's that cognitive rehearsal to address incivility and maybe some other, situations that are really hard to navigate. And it's this evidence-based strategy that helps individuals kind of practice effective responses to, let's just say, incivility or, something that's happening at the bedside before it even happens. So you have it in your mind. And it shows that as you use this kind of pre-briefing and learning and kind of scripting, role-playing, rehearsal, that it actually increases your confidence and reduces your anxiety and strengthens kind of that kind of personal effectiveness. And I've used this strategy several times, and it really has helped kind of navigate disruptive or high stress situations, and gives you kind of that great clarity and control. So something to think about, it's evidence-based, there's articles out there, but it's cognitive rehearsal to address those situations.
I'll have to check that out. I mean, that definitely, you get in those situations and you can't find the words to say.
Right.
So if we can give people simple phrases and words to kind of cling onto and be able to say when they're a little shell-shocked and a little like, oh my gosh, I don't even remember CPR right now. What's going on? You freeze at the bedside. If we can give them talking points to reference, I think that really is empowering. And then when they calm down and get used to these situations, and those nurses on your unit who are used to those situations and can say what they need to say quickly, it's because they've gotten desensitized to them and they're able to practice assertiveness at the same time.
So to wrap up our conversation, what is one spark or one piece of wisdom or encouragement you would want every nurse educator to kind of carry forward as they support the next generation of nurses?
I think my spark would be to teach with the reality in mind. New nurses are trying to use your education inside chaos, and they won't always tell you what's missing. So make it safe to be honest, remove as many unknowns as possible early, and measure success by whether practice changes, not whether or not the program checks all the boxes.
Kati, thank you so much for sharing your insight, clarity, and definitely your honesty with us today. Your perspective sheds light on the deeper skills and mindset new nurses truly need and how educators can play a transformative role in that journey. Thanks again, Kati.
Oh, thank you for having me.
Thanks for listening to Lippincott Spark. Be sure to subscribe, share with a colleague, and leave us a 5-star review. You'll find links below to learn more about Lippincott nursing products and services. Until next time, keep learning, keep leading, and keep sparking innovation in nursing education.